Hi, viewers. Welcome to this discussion. Today, we will be talking about aortic stenosis, a common heart valve disorder that affects millions of people globally. Aortic stenosis occurs when the aortic valve narrows, obstructing blood flow from the heart to the rest of the body. So, subscribe to this channel and let's dive into this important topic. Let's take a look at this illustration. So, we have the left ventricular chamber, we have the mitral valve, we have the aorta, and we have the aortic valve, which has a cross-sectional area of about 3 to 4 centimeter squared. In aortic stenosis, there is a narrowed aortic valve right here. And this is quite serious because the narrow valve obstructs the flow of blood from the left ventricular chamber into the aorta. And you agree this is serious because there is going to be a decrease in the cardiac output. So, in fact, when there is a decline in the cardiac output, we're talking about what happens inside the aorta. So, this is because of a stroke volume which is generated inside the left ventricular chamber but does not get into the aorta. So, the stroke volume will decrease inside the aorta. And so this is very important to understand that there is a pressure overload inside the left ventricular chamber. But inside the aorta, there is a decline in the cardiac output, there is a decline in the stroke volume. So we can say that the systolic blood pressure inside the aorta is actually decreased, but there is hypertension inside the left ventricular chamber. Now, a question. So, what happens to the stroke volume in aortic regurgitation? You're right if you said it increases. In aortic regurgitation, there is a volume overload. In contrast to aortic stenosis, there is a pressure overload in the left ventricular chamber. Now, this is because of a continuous impedance to ejection. So, the aortic defect or the narrowed aortic valve causes a continuous obstruction to the ejection of blood, and this will lead to a concentric left ventricular hypertrophy. Hypertrophy can lead to an increase in the demand of oxygen. Nevertheless, you also recall that coronary perfusion is also going to be impaired because of the obstruction. Blood doesn't get through the aortic valve, and so there is going to be coronary perfusion impairment. So there is also going to be supply ischemia. And a substantial chronic rise in the diastolic pressure that is inside the aortic chamber will eventually lead to a congestive heart failure. However, the systolic function is usually preserved until later in the course of the disease. Another important thing is that a diastolic dysfunction may also be associated as a result of a left ventricular chamber stiffness. So this part becomes stiff because of the remodeling. And when the left atrium tries to contract against a stiff ventricle, this leads to the S4 sound that is noticed on auscultation. So it is notable that in aortic stenosis, there is pressure overload in the left ventricle. The poor left ventricle is trying to push that stroke volume against resistance because of the narrowed aortic valve. So it actually takes time for the poor left ventricle to get some of the stroke volume into the aorta. And so there is a delay in the closure of the narrowed aortic valve. So, in general, we can say that there is a decline in the cardiac output, and this is directly proportional to the stroke volume. So, the stroke volume also decreases, and this manifests as a diminished carotid artery pulse, which is also seen to have a prolonged duration. Now, let's try to simplify what arterial pressure waveform is. What I have here on the left is a normal arterial pressure waveform. This starts with the systolic phase, which also represents the beginning of a ventricular ejection up to the peak systolic pressure. So it starts with a fairly sharp upstroke. From here, you can see that this is a sharp upstroke. It's fairly sharp. Then it reaches the peak systolic pressure. And as you can see, there is a decline in the systolic pressure. Now, at this point, you can see that there is two limbs. We call this the dichrotic limb. And it is important because it simply refers to two impulses which is felt for each heartbeat. So the part here, we call it the dichrotic notch, and it marks the beginning of diastole. This is actually the point where the aortic valve closes, and it is also important to understand that it is also the point where we notice the flow of blood into the peripheral circulation. So as you can see, this is the systolic blood pressure, and this is the diastolic blood pressure. So the difference between these two right here, we will call it the pulse pressure. So I guess you know what mean arterial pressure is, and most textbooks would use the formula that is mean arterial pressure is equal to the diastolic pressure, which we have right here. So we have diastolic blood pressure plus actually 1/3 of what? Of the pulse pressure. Okay, and so that's going to be plus 1/3 of the pulse pressure. So if you trace it, that's going to be somewhere here. And this will be the mean, say, arterial pressure. All right, but it is better to use the area under the curve. Now let's take a look at what happens in aortic stenosis on the right. So you can see that there is a diminished carotid artery pulse. You can see the slow rising upstroke. So the upstroke is actually decreased, and you can see a late peak in general, as I said. So take a look. If this is the diastolic blood pressure, then we could also say that this is the systolic blood pressure. So in general, you can see the difference that the pulse pressure is actually narrow compared to what we saw normally. Why? Because the systolic blood pressure has decreased. Why? Because there is a decline in the stroke volume. And so the systolic blood pressure in the aorta is decreased. So we see a diminished carotid artery impulse with aortic stenosis. Now let's try to compare the differences between normal physiological split of S2 sound and a paradoxical split of S2 sound, which we see in aortic stenosis. Now you recall that S1 heart sound represents mitral and tricuspid valve closure. Both of them closes almost simultaneously, hence there is no split in S1. So this is S1, it has no split. But you can notice from S2, which is the aortic valve and the pulmonary valve closure. But these two valves do not close simultaneously. Hence, there is going to be a split. So this is S2. And you can see that it has the aortic valve closure, which is going to be A2, and the pulmonary valve closure, which is going to be P2. All right. Now you remember that the closing pressures in the left ventricle, that is actually also the diastolic pressure, and that is 80 millimeter mercury. And the closing pressures in the right ventricle is actually 10 millimeter mercury. So the pressure in the left ventricle is high to close the aortic valve earlier than the right ventricle. Moreover, the left ventricle itself is quite powerful because of its muscular structure. So that's also very important to understand why A2 occurs earlier than P2 in the normal physiological split. So aortic valve normally closes earlier than the pulmonary valve. Now, again, during inspiration, there is a more blood pooling in the right ventricle, which also delays the closure of pulmonary valve, that is P2. So when you breathe in deeply, what happens is that there is going to be a wide, but it is still physiological. There's going to be a split between A2 and P2 as a result of P2. As I already said, that there's a delay in the closure of pulmonary valve because of more blood pooling in the right ventricle during inspiration. So this is what we see with normal physiological split. Let us take a look at what paradoxical split of S2 is. So you can see that there is actually a difference in the sense that this is the opposite of what happens in normal physiological split. You can now see that the pulmonary valve closure is heard first before the aortic valve. So why? Well, of course, this occurs in aortic stenosis as a result of delay in the ejection due to the late closure of the stenosed aortic valve. So you hear P2 before A2, and this occurs in expiration because we said this is the opposite of what happens in normal physiological split. So in normal physiological split, you would rather have the split during inspiration. That is when during inspiration, when you put in more air into your lungs, you increase the volume. And of course, this would lead to more blood pooling in the right ventricle. So, any pathology that delays the closure of aortic valve can actually lead to a paradoxical split of S2. Can you think of any of those diseases? Well, I will name two, and you can write the third one in the comment section. So the first one is going to be severe aortic stenosis, and the second one is going to be a left bundle branch block. On auscultation for aortic stenosis, there is a harsh crescendo decrescendo systolic murmur that starts after S1 and peaks at mid-systole and radiates to the carotid. Diagnostics. So echocardiogram is diagnostic for aortic stenosis and it is very useful. Aortic valve area that is less than 1 centimeter squared is significant for stenosis, and aortic valve area that is less than 0.7 centimeters squared is actually indicative of a critical stenosis. A pressure gradient greater than 50 millimeter mercury is significant for severe aortic stenosis, and aortic valve velocity greater than 4 meter per second is a sign of severe aortic stenosis. A pressure gradient that is less than 50 millimeter mercury with a concomitant ischemic heart disease or heart failure is also a sign of severe aortic stenosis and may be an indication for a surgical intervention. An electrocardiogram may show a left ventricular hypertrophy or signs of ischemia. Chest x-ray may be used to assess cardiomegaly, post-stenotic dilation, as well as calcifications. Cardiac catheterizations may be used to assess the severity or a left ventricular function. Angiography or a radionuclide ventriculography may also be used. You may also evaluate for a congestive heart failure if there are signs. Management. So, a moderate to severe aortic stenosis has a high mortality rate with medical treatment alone for up to about 50%. This is quite significant. Hence, the answer is an on time valve replacement is the recommended treatment modality. Percutaneous valvuloplasty may be an option for unfit patients that are unable to undergo valve replacement, and a transcatheter aortic valve implantation may also be tried. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.